Hi everyone, welcome back to my YouTube channel. In today's video, I will be talking about the proposed rule CMS has issued for calendar year 2024 Medicare Physician Fee Schedule. Let's dive right in. On July 13th of 2023, the Centers for Medicare and Medicaid Services or CMS issued a proposed rule that announces and solicits public comments on proposed policy changes for Medicare payments under the Physician Fee Schedule or PFS and other Medicare Part B issues effective on or after January 1st, 2024. Some of the key takeaways are as follows. Background on the Physician Fee Schedule. Since 1992, Medicare payment has been made under the Physician Fee Schedule for the services of physicians and other billing professionals. Physician services paid under the Physician Fee Schedule are furnished in a variety of settings, including physician offices, hospitals, ambulatory surgical centers, skilled nursing facilities, and other post-acute care settings, hospices, outpatient dialysis facilities, clinical laboratories, and beneficiaries' homes. Payment is also made to several types of suppliers for technical services, most often in settings for which no institutional payment is made. For most services furnished in a physician's office, Medicare makes payment to physicians and other professionals at a single rate based on the full range of resources involved in furnishing the service. In contrast, Physician Fee Schedule rates paid to physicians and other billing practitioners in facility settings such as a hospital outpatient department or HOPD or an ambulatory surgery center reflect only the portion of the resources typically incurred by the practitioner in the course of furnishing the service. For many diagnostic tests and a limited number of other services, under the Physician Fee Schedule, separate payment may be made for the professional and technical components of services. The technical component is frequently billed by suppliers like independent diagnostic testing facilities and radiation treatment centers, while the professional component is billed by the physician or practitioner. Payments are based on the relative resources typically used to furnish the service. Relative value units or RVUs are applied to each service for work, practice expense, and malpractice expense. These RVUs become payment rates through the application of a conversion factor. Geographic adjusters or geographic practice cost indexes are also applied to the total RVUs to account for variation in cost by geographic area. Payment rates are calculated to include an overall payment update specified by statute. Calendar year 2024 Physician Fee Schedule rate setting and conversion factor. By factors specified in law, overall payment rates under the Physician Fee Schedule are proposed to be reduced by 1.25% in calendar year 2024 compared to calendar year 2023. CMS is also proposing significant increases in payment for primary care and other kinds of direct patient care. The proposed calendar year 2024 Physician Fee Schedule conversion factor is $32.75, which is a decrease of $1.14 or 3.34% from the current calendar year 2023 conversion factor of $33.89. Caregiver training services. For calendar year 2024, CMS is proposing to make payment when practitioners train and involve caregivers to support patients with certain diseases or illnesses, example dementia, in carrying out a treatment plan. CMS is proposing to pay for these services when furnished by a physician or a non-physician practitioner such as nurse practitioners, clinical nurse specialists, certified nurse midwives, physician assistants, and clinical psychologists or therapists, physical therapist, occupational therapist, or speech language pathologist under an individualized treatment plan or therapy plan of care. Services addressing health-related social needs. community health integration services, social determinants of health risk assessment, and principal illness navigation services. For calendar year 2024, CMS is proposing coding and payment changes to better account for resources involved in furnishing patient-centered care, involving a multidisciplinary team of clinical staff and other auxiliary personnel. These proposed services are aligned with the HHS Social Determinants of Health Action Plan and also help implement the Biden-Harris Cancer Moonshot goal of every American with cancer having access to covered patient navigation services. Specifically, CMS is proposing to pay separately for community health integration, social determinants of health or SDOH risk assessment, and principal illness navigation services to account for resources when clinicians involve community health workers, care navigators, and peer support specialists in furnishing medically necessary care. While these care support staff have been able to serve as auxiliary personnel to perform covered services incident to the services of a Medicare enrolled billing physician or practitioner, the services described by the proposed codes are the first that are specifically designed to describe services involving community health workers, care navigators, and peer support specialists. Community Health Integration or CHI and Principal Illness Navigation or PIN services involve a person-centered assessment to better understand the patient's life story, care coordination, contextualizing health education, building patient self-advocacy skills, health system navigation, facilitating behavioral change, providing social and emotional support, and facilitating access to community-based social services to address unmet social determinations of health needs. Community health integration services are to address unmet social determinants of health needs that affect the diagnosis and treatment of the patient's medical problems. Principal illness navigation services are to help people with Medicare who are diagnosed with high-risk conditions, for example, mental health conditions, substance use disorder, and cancer, identify and connect with appropriate clinical and support resources. CMS is further clarifying that the community health workers, care navigators, peer support specialists, and other such auxiliary personnel may be employed by community-based organizations or CBOs as long as there is the requisite supervision by the billing practitioner for these services, similar to other care management services. In addition to better recognizing costs associated with patient-centered care, access to these services could contribute to equity, inclusion, and access to care for the Medicare population and improve the outcomes for the patient, particularly in rural health clinics, federally qualified health centers, underserved and low-income populations where there is a disparity in access to quality care. CMS is also proposing coding and payment for social determinants of health risk assessments to recognize when practitioners spend time and resources assessing social determinants of health that may be impacting their ability to treat the patient. Additionally, CMS is proposing to add the social determinants of health risk assessment to the annual wellness visit as an optional additional element with an additional payment. Separately, CMS is also proposing codes and payment for social determinants of health risk assessments furnished on the same day as an evaluation and management visit. Evaluation and management visits. Beginning January 1st of 2024, CMS is proposing to implement a separate add-on payment for Healthcare Common Procedure Coding System or HCPCS code G2211. This add-on code will better recognize the resource cost associated with evaluation and management visits for primary care and longitudinal care of complex patients. Generally, it will be applicable for outpatient office visits as an additional payment, recognizing the inherent costs clinicians may incur when longitudinally treating a patient's single serious, or complex chronic condition. If finalized, CMS expects that establishing payment for this add-on code would have redistributive impacts for all other calendar year 2024 payments, which comparatively are less than what CMS initially estimated for this policy in calendar year 2021 under the Medicare Physician Fee Schedule due to statutory budget neutrality requirements. CMS originally finalized this policy in the calendar year 2021 Medicare Physician Fee Schedule final rule. However, Congress suspended the use of the add-on code by prohibiting CMS from making additional payment under the Physician Fee Schedule for these inherently complex evaluation/management visits before January 1, 2024. Since this policy would improve the accuracy of payment for primary and longitudinal care, CMS is proposing to implement the policy this year. CMS is proposing refinements to the policy, however, after considering information from interested parties who shared feedback in earlier rulemaking about their utilization assumptions and the estimated redistributive impact of the code on physician fee schedule payments. These changes have reduced the redistributive impacts of this policy. Specifically, CMS is proposing that the add-on code would not be billed with a modifier that denotes an office and outpatient evaluation and management visit that is itself unbundled from another service. Example, a procedure where complexity is already recognized in the valuation. Second, CMS has defined their utilization estimates for HCPCS code G2211 in response to public feedback. These refinements collectively reduce the redistributive impact to the calendar year 2024 CF by nearly one-third of the estimated impact described in the calendar year 2021 Medicare Physician Fee Schedule final rule. Split or shared evaluation and management visits. Split or shared E/M visits refer to visits provided in part by physicians and in part by other practitioners in hospitals and other institutional settings. For calendar year 2024, CMS is proposing to delay the implementation of their definition of the substantive portion as more than half of the total time through at least December 31, 2024. Instead, CMS is proposing to maintain the current definition of substantive portion for calendar year 2024 that allows for use of either one of the three key components, history, exam, or MDM, or more than half of the total time spent to determine who bills the visit. Telehealth services under the Physician Fee Schedule. For calendar year 2024, CMS is proposing to add health and well-being coaching services to the Medicare telehealth services list on a temporary basis for calendar year 2024 and social determinants of health risk assessments on a permanent basis. CMS is also proposing a refined process to analyze requests received for addition of services to the Medicare telehealth services list, including a determination on whether the requested services should be added permanently or provisionally. CMS is proposing to implement several telehealth-related provisions of the Consolidated Appropriations Act of 2023, including the temporary expansion of the scope of telehealth originating sites for services furnished via telehealth to include any site in the United States where the beneficiary is located at the time of the telehealth service, including an individual's home, the expansion of the definition of telehealth practitioners to include qualified occupational therapists, qualified physical therapists, qualified speech language pathologists, and qualified audiologists. The continued payment for telehealth services furnished by rural health clinics and federally qualified health centers using the methodology established for those telehealth services during the public health emergency. CMS is also proposing to implement delaying the requirement for an in-person visit with the physician or practitioner within 6 months prior to initiating mental health telehealth services, and again at subsequent intervals as the Secretary determines appropriate, as well as similar requirements for rural health clinics and federally qualified health centers, and the continued coverage and payment of telehealth services included on the Medicare telehealth services list as of March 15, 2020 until December 31st, 2024. CMS is proposing that beginning in calendar year 2024, telehealth services furnished to people in their homes be paid at the non-facility physician fee schedule rate to protect access to mental health and other telehealth services by aligning with telehealth-related flexibilities that were extended via the Consolidated Appropriations Act of 2023. CMS is proposing to continue to define direct supervision to permit the presence and immediate availability of the supervising practitioner through real-time audio and video interactive telecommunications through December 31st, 2024. CMS believes that extending this definition of direct supervision through December 31st, 2024 would align the time frame of this policy with many of the previously discussed public health emergency related telehealth policies that were extended under provisions of the Consolidated Appropriations Act of 2023. CMS is soliciting comment on whether they should consider extending the definition of direct supervision to permit virtual presence beyond December 31st, 2024. Specifically, CMS is interested in input from interested parties on potential patient safety or quality concerns when direct supervision occurs virtually. Collectively, these proposed policies, if finalized, will continue many of the flexibilities that practitioners have had during the public health emergency to furnish telehealth services until the end of 2024 as per statutory requirements. Telehealth services, both audiovisual and audio only, have enabled individuals in rural and underserved areas to have improved access to care. Telehealth services furnished in teaching settings. CMS is proposing to allow teaching physicians to use audio/video real-time communications technology when the resident furnishes Medicare telehealth services in all residency training locations through the end of calendar year 2024. This virtual presence would meet the requirement that the teaching physician be present for the key portion of the service. CMS is seeking comment on other clinical treatment situations where it may be appropriate to allow the virtual presence of the teaching physician and could consider finalizing these in the calendar year 2024 Physician Fee Schedule final rule. Payment for outpatient therapy services, diabetes self-management training or DSMT, and medical nutrition therapy or MNT when furnished by institutional staff to beneficiaries in their homes through communication technology. Institutional providers are able to continue to bill for services on the telehealth list furnished remotely the same way they could during the public health emergency through the end of calendar year 2023. CMS is proposing to continue to allow institutional providers to bill for outpatient therapy, diabetes self-management training, and medical nutrition therapy services until the end of calendar year 2024. CMS is also seeking comment about the effectiveness of these services when furnished remotely compared to in-person. Opioid treatment programs or OTPs. CMS is proposing to extend current flexibilities for periodic assessments that are furnished via audio-only telecommunications through the end of calendar year 2024. CMS would allow opioid treatment programs to bill Medicare under the Part B OTP or Opioid Treatment Program benefit for furnishing periodic assessments via audio-only telecommunications when video is not available to the beneficiary, to the extent that use of audio-only communications technology is permitted under the applicable Substance Abuse and Mental Health Services Administration and DEA requirements at the time the service is furnished, and all other applicable requirements are met. Supervision policy for physical and occupational therapists in private practice. CMS is proposing a regulatory change to allow for general supervision of their therapy assistants by PTs in private practices and OTs in private practices for remote therapeutic monitoring or RTM services. This will align with the Remote Therapeutic Monitoring General Supervision Policy that CMS finalized in their calendar year 2023 rulemaking. CMS is also soliciting comments on whether to revise the current direct supervision regulatory policy for PTs in private practices and OTs in private practices of their therapy assistants to the general supervision policy for all services, not just for remote therapeutic monitoring services. CMS is particularly interested in receiving comments, including any available supporting data on the potential effects of implementing such a policy, including but not limited to patient quality of care, patient safety, and changes in utilization. Medicare Part B payment for preventive vaccine administration services. In June 2021, CMS announced an additional payment for in-home COVID-19 vaccine administration, which was established on a preliminary basis during the public health emergency. Based on data that show that this payment has helped improve healthcare access to vaccines for underserved Medicare populations, CMS is proposing to maintain this additional payment for the administration of COVID-19 vaccine in the home. CMS is also proposing to extend this in-home additional payment to the administration of the other three preventive vaccines included in the Part B preventive vaccine benefit, the pneumococcal, influenza, and hepatitis B vaccines when provided in the home. Under this proposal, effective January 1, 2024, the payment amount for administration of all four vaccines would be identical. That is, Medicare Part B will pay the same additional payment amount to providers and suppliers that administer a pneumococcal, influenza, hepatitis B, or COVID-19 vaccine in the home. Medicare and Medicaid provider and supplier enrollment. CMS is proposing several regulatory provisions regarding Medicare and Medicaid provider enrollment. These include, but are not limited to, the following: creation of a new Medicare provider enrollment status labeled a stay of enrollment, which CMS believes will ease the burden on providers and suppliers while strengthening Medicare program integrity. Requiring all Medicare provider and supplier types to report additions, deletions, or changes in their practice locations within 30 days. CMS is proposing to establish several new and revised Medicare denial and revocation authorities. CMS is also proposing to clarify the length of time for which a Medicaid provider will remain in the Medicaid termination database. This is it for today. Thank you for joining me. If you enjoyed this video, please consider subscribing to my channel. Hope to see you next time. Bye now.